Hello all, good evening for this session. I welcome you all for Wednesday special sessions under Plan C Plus under NNL Academy. Your mastermind faculty Muthukumaran here to overview a beautiful topic today. I am very happy to take the class. Yes, hope you're all very good in your preparations for NORCET 9. Yes, anybody? Can anyone please confirm whether my audio and video is good, whether my audio is you can audible and video is visible? Good evening all. Somya Singh, Priya, Sirisha, yes, good evening all. Good evening. Very glad to meet you all people. Yes. Come on now. With this picture, can anyone tell what is the topic? Can anyone tell? Yes, thank you. Please tell the topic what we are going to discuss today. Yes? So this is the voice throw and voice delay is due to the network issue. Okay, you can check your network issue, students, so that yes, forceps delivery. Okay, so you can see the knife is cutting the baby. Normally the baby is there, okay, but the hand is showing some abnormal sign. Zavia, yes, hi, good evening to all. No, it's not forceps delivery. Till now we have seen in the past topics from menstrual cycle till now we have seen about the baby normal activity, infertility where there is no point of conception. What are the things? Now it is related to labor, that is related to labor, but we can say consider a woman, okay, having a have conceived, but there is a problem in 20th week, okay, there is a problem in 20th week where there is a profuse bleeding is there due to some trauma. So what we will tell the condition, okay, due to the trauma. Yes, yes, come on. Yes, that is abortion. You people got the point. That is abortion. Yes, we are going to discuss about abortion every year. You don't believe, every year in coming to the NORCET aspect, before NORCET 4 there was 200 questions. In that 2 to 3 questions were asked from abortion. 2 questions came from abortion, and abortion is very important topic. Related to that we are going to do see the cervical circlage also. Very important topic. I will clear the topic today, and I am damn sure you will be attending whichever questions comes from abortion. Okay, yes, are you ready? We are going to learn today 2 MCQs. Okay, yes. Coming, what is the definition? If there is a loss of viable pregnancy before 20 weeks, then we will say abortion, or the fetal weight should be less than 500 gram. This is the definition for abortion, okay. And when we are calculating this GT-PAL also we will be considering na, where this is gravida, term birth, preterm, abortion and live child. In abortion, how we will be calculating whether the period of gestation is viable or not, if it is more than 20 weeks or less than 20 weeks. then we are going to consider this as abortion. Okay, less than 20 weeks. Before 20 weeks, fetal weight should be less than 500 gram, then we can say that is abortion. Is it clear for you all? Please turn on your volume. The volume is good. Okay, volume is good, students. Yes. Then another one thing, fetal weight at 20 weeks, it approximately 330 gram, and fetal weight at 22 weeks, it's 500 gram. Okay, 22 weeks the fetal weight will be 500 gram. What is the exact definition is, for abortion the fetal weight should be less than 500 gram and before 20th week, then we are calling it as abortion. Okay, yes. Is it clear? The voice is audible. I am also listening through my phone. You can see the voice is audible and it is clear. Please check your network and turn on your mobile phone volume. Okay, please students. Yes. Now we are going to discuss what are the types. Coming on to this recurrent abortion. What is recurrent abortion here? There is a loss of 3 or more consecutive pregnancy, then we are naming it as recurrent abortion. So abortion is less than 20 weeks. Okay, less than 20 weeks of 500 grams, less than 500 grams. Okay, then we can say that is abortion. If it is recurrent abortion, there is 3 consecutive loss of pregnancy, then we can say that is recurrent abortion. The term differs here. Okay, they may give you the term also, that is simple definition they may ask. Okay, yes. Next question. Next thing is, here comes your MCQ point. Which is the most common cause for spontaneous abortion in trimester 1 and trimester 2? That is, first thing we can give aneuploidy. Second is trisomy and monosomy X and trisomy 16. These are chromosomal defects. Chromosomal defects. That is spontaneous abortion in trimester 1 and trimester 2. What is trimester 1 and trimester 2? Trimester 1 is, already we have discussed. Trimester 1 is, come on, anybody? Trimester is from week of 1 to 12 weeks. From the week of 13 to 28 weeks. That is trimester 2. Okay. Yes, trimester 2 abortion. Most common cause of uterine cause. Okay, trimester 1 abortion. Uterine causes septate uterus. This is Mullerian malformation. Mullerian malformation. Where there in septate uterus, the septum will not fuse, right? This is the mons pubis. This is the septum. Okay, septum will not fuse. Okay, consider this as the fuse. Okay, this is the fallopian tube. Okay, yes, there won't be fusion takes place, so that abortion is common in septate uterus. We are having unicorticate uterus, didelphys uterus. Like in septate uterus is the most common cause in trimester 1 uterine cause. Okay, uterine cause of abortion, that is septate uterus. Okay, yes. Coming on to the next, most common uterine cause of trimester 2, that is cervical incompetence. What is cervical incompetence? The cervix has to be closed. If there is opening, there is a dilatation of the cervix more than 2.5 centimeter, so there may be not viability of the fetus to grow inside. So there may be a chance of bleeding. So in second trimester, if there is uterine cause, that is due to cervical incompetence, then we can say it as cervical insufficiency. Related to that condition, what is the management also today we are going to see. Okay, Next, most common overall cause of recurrent pregnancy loss. Recurrent pregnancy loss, that is APLA syndrome, that is antiphospholipid antigen syndrome, where the phospholipids in the body, right, it may perceive the fetus antibody as foreign object, and the prostaglandins which is produced inside these phospholipids will attack our immune system. That is APLA syndrome, that is antiphospholipid antigen syndrome. That is the most common cause, overall cause of recurrent pregnancy loss, that is about 16%. Okay, that is the most common cause. Very, very important. Okay, this is very, very important. Okay, next come most common group causing that is recurrent pregnancy loss, that is endocrine causes and uterine causes due to hypothyroidism. Is there any problem with hypothalamus? Okay, then uterine causes are the group. Uterine causes already we have discussed, that is septate uterus. Okay, this is the important thing you should note. Which is the very important point? Uterine causes, septate uterus. 1 MCQ. Okay, 1 MCQ. And spontaneous trimester 1, trimester 2, that is due to chromosomal defect, aneuploidy. And coming on to the uterine cause, that is trimester 2, if they specifically ask trimester 2, that is due to cervical incompetence. Okay, yes. Is there any doubt, children? Yes, roughly I have written, that is trimester 1 is 1 to 12 weeks. Trimester 2 is 13 to 28 weeks. Plus 6 days and all you can add. Okay, that is roughly I have written. First 3 months, 3 months and 3 months we are dividing, right? That is the average thing I have written. Okay, yes. Coming on to the types of abortion. This is very important where your MCQ are coming. Okay. Till now, what is the most common cause we have discussed? Most common cause will be chromosomal defect. Uterine cause, if they specifically ask, uterine cause in trimester 1, that is septate uterus. Trimester 2, if they ask, that is due to cervical incompetence. Okay? Yes. Fine. Now we are going to see what are the types of abortion. Threatened abortion, yes. Inevitable abortion, incomplete abortion, complete abortion, and missed abortion. Lastly, septic abortion. In this, we can divide with the cervical os opening and closing. Threatened abortion happens due to the trauma or any other external cause which threatens the uterus and separates the fetus. Okay, sometimes it may cause fetal death also, but it is having the mild bleeding with mild pain. Fetus will be alive on USG. That is always threatened abortion. So uterus is safe. Some points, most of 99%, the fetus will be safe. Only mild pain will be there, that is threatened abortion. In that, the cervical os, here the cervical os will be closed or open. It is closed. No expulsion will be there. Coming on to the next, inevitable abortion. Inevitable abortion where pain will be there. Along with pain, bleeding will be there. Cervix is dilated. Cervix is dilated. Fetus may be alive or not. That is the only thing you should know. Fetus will be alive or not. Okay. No expulsion yet. Yes, no expulsion. Abortion is inevitable. So it is inevitable. So always inevitable will be the cervical os will be open. So bleeding is there. So cervical os will be opened here. Coming on to the next, incomplete abortion. Incomplete abortion also same, pain with heavy bleeding will be there. Partial expulsion of products of conception. This is the key word you should note. partial expulsion of period of conception, but inevitable products of conception will not be there. Products of conception means fetal parts or any other components will not be there in inevitable. Incomplete, there will be partial expulsion of products of conception. Yes. So in incomplete abortion also, the cervical os will be open. Partially expelled, some products of conception remains inside. Some products of conception will be remaining inside. Now here comes the complete abortion. In complete abortion, presently there won't be bleeding, but there will be a history of bleeding. Okay, history of bleeding will be there, but now while assessment will not be there, and uterus is contracted. All products of conception are expelled. So now bleeding is not there. So it is closed. Cervical os will be closed. Next, missed abortion. This is very important. Repeatedly asked questions. No symptoms or mild spotting. Fetus non-viable on UST. Okay, no cardiac activity. Fetus is death. Okay, fetus is death. So no bleeding. So missed abortion is cervical is also closed. No expulsion. Retained non-viable fetus. The components will be inside, but it's not expelled out. So that is missed abortion. Coming on to the septic abortion due to some infection, okay, related to fever, false discharge will be there, pelvic tenderness will be there. Okay, here also cervical os will be closed. The products of conception will be retained, and infection is present. So infection is present. Only two things you are going to do, that is inevitable and incomplete, the cervical os will be open. Okay, incomplete and inevitable. Other than that, all these cervical os will be closed. 2 points over. Now here comes inevitable and incomplete. So inevitable in the sense it is not evitable. So what happens? Products of conception will be remaining inside. In incomplete, some parts, all the product of conceptions are, here comes incomplete and inevitable. Some products will be expelled out, that is in incomplete. Inevitable, no expulsion. Some products, no complete expulsion will be there. If there is partially expelled out, that is incomplete. Inevitable, no products will be expelled. But in complete, all products of conception are expelled but remains closed. Okay? Yes. Yes, correct. Complete os closed. Correct? Yes. Coming on to the next thing. Is it clear for you all now? Types of abortion. There are threatened abortion and missed abortion and septic abortion, complete abortion. Okay. Other than that, incomplete and inevitable. Incomplete and inevitable, the cervical os will be open. But other than that, threatened abortion, missed abortion, complete abortion, the cervical os will be closed. Okay? Yes. There won't be bleeding will be present, but presently there won't be bleeding. In missed abortion, the fetal activity will not be there. In complete abortion, fetal activity is maybe present or maybe not. And in threatened abortion, most probably 99%, the fetus will be alive. Okay? Yes. Now, for threatened abortion, what is the expected management? If threatened abortion patient comes, we have diagnosed, only we are going to do bed rest serial USG, okay, weekly, or we are going to do what is the activity of the fetus. Coming on to the inevitable, so it is retained inside, right? No product of conception are coming out. So suction is evacuated. Suction evacuation we are doing if heavy bleeding is there. Heavy bleeding will be there, right? So we are going to suction and evacuation we are going to do. In incomplete, so emergency suction evacuation we are going to do. In incomplete, so heavy bleeding will be there, right? Pain plus heavy bleeding, product of conception, somehow they are expelled. POC expelled, somehow they are expelled, right? So we are going to do emergency suction and evacuation. In complete abortion, what we are going to do? We have to observe. If IUP is confirmed, no further action can be taken. Okay, no further action can be taken. Coming on to the missed abortion, medical or surgical evacuation as per appropriate things we are going to do. Okay, as per the medical and surgical evacuation, as per appropriate, we are going to do for missed abortion. Because in missed abortion, fetus is not viable. We cannot able to predict. After some days or some months only, we are going to identify. Yes, correct. These are the terms. Okay, in types of abortion with pictorial representation, again I am going to reinforce you. Okay, threatened, inevitable, incomplete, complete, and missed. Here you can see in threatened there is suppression. Okay, suppression is there, but the cervical os is closed. The fetal cervical os is closed. Cardiac activity is present. In inevitable, may be or may not. Cervical os is open. Okay, you can see the bleeding here. You can see the bleeding here. In incomplete also, there is open, the fetus is coming outside. Some part of the fetal products of conception are coming out. Okay, so cervical os is open and fetal activity is no. Here comes the complete. Products of components are coming out. There is no inside, no product of coming, all comes out. Incomplete, so it is complete. Completely all products of conception coming out. Cervical os is closed and fetal activity no. Missed abortion, no fetal activity. Somehow the cervical os is closed. Cervical os is closed. Is it clear for you all? The treatment I have discussed with the MCQ we will practice. Don't worry, I will clarify you that itself, because sometime we will have confusion whether what to do for threatened abortion, what to do for incomplete and inevitable. So that with MCQs we will practice and we are going to be had the clarity. Okay? Yes. Is it clear for you all? With the pictorial representation, we have discussed threatened, inevitable, incomplete, complete, and missed abortion. Major thing you want to note, that is cardiac activity. Only two things. In threatened abortion, there is 99% fetal will be viable. But in incomplete, 50% chance. Only 50% chance. May be present or maybe not. That is inevitable. We cannot able to predict. Incomplete and complete missed, there won't be fetal activity. Yes? Yes. In missed abortion, we can do, yes, dilatation curettage we can do, we can expel the fetal. Okay? Yes, we can expel the fetus. Next come diagnosis of missed abortion. Why we are focusing on missed abortion diagnosis? Because we cannot able to predict whether the mother is having missed abortion or not. Only with USG, first USG criteria is, that is mean sac diameter. Mean sac diameter. This mean sac diameter should be greater than 25 to 30 and no yolk sac or fetal pole, then we can confirm missed abortion. Then here comes the important point, crown rump length. If the crown rump length is more than or equal to 7 with no cardiac activity, then we can confirm it as missed abortion. Previously seen cardiac activity, but now it is absent. Consider trimester 1, the mother comes, cardiac activity is present, crown lump is normal. Then second trimester, another 2 weeks or 3 weeks, if she comes, again it shows crown rump length with no cardiac activity, mean sac diameter is more than 25, no yolk sac, then we can confirm it's missed abortion. Okay? Then obviously then we are going to do dilatation and curettage. Yes? Yes. Next, coming on to this investigation for recurrent, that is pregnancy loss. Okay, for recurrent pregnancy loss. recommended test, that is transvaginal sonography, uterine assessment we are going to do. And coming on to this APLA, already I have told, that is anti-phospholipid antigen antibody panel we are going to do for recurrent pregnancy loss, and TSH, thyroid stimulating hormone, and parental karyotyping, because chromosomal defects are more. These are the recommended investigations. First thing, that is TVS, APLA syndrome, TSH, and parental karyotyping. These are the important assessment we are going to do for this recurrent pregnancy loss. Which is not needed, that is TORCH, that is toxoplasmosis, that is rubella, and chlamydia herpes simplex virus. Okay, we are not going to do this HIV and venereal diseases. It is not recommended for recurrent pregnancy loss. These are the mandatory tests: transvaginal sonography, APLA, and thyroid parental karyotyping. These are the important points you should note. Okay, yes. Yes, intrauterine pregnancy is the correct. IUP is correct. Sorry, I forgot to tell that where it is. Yes. Complete abortion, it may be intrauterine pregnancy confirmed. No, we can do further action. If it is not intrauterine, then we can do the further action. Further action in the sense whether we are going to do dilatation, curettage, because some part are expelled out, but the os remain closed. We are going to do that. Okay, yes. Yes. Coming on to, till now we have discussed about abortion, right? What is abortion? What are the types of abortion? How we are going to manage, and specific treatment we have discussed. And important, that is for missed abortion. This is the important parameters where highly focused MCQ. Why I am focusing here? Because they may not give the scenario like, that is abortion like symptoms. Okay, consider a scenario: a so-and-so mother coming to the antenatal clinic having crown rump length of 7 mm, that is 8 mm, and fetal cardiac activity is not. What may be the expected condition, they may ask. So that time you should think. They may give only one option, that is missed abortion, and another things are not related to that. Okay, cervical incompetence maybe, or karyotyping, like chromosomal defects, like that they may give. So you should be confident. If crown rump length is more and no fetal cardiac activity, then it is missed abortion. Then it is missed abortion. So that I am stressing this point. This is the expected MCQ. Expected MCQ. Okay, is it fine? Yes. Is it fine, children? That we will discuss. Yes. That is maternal termination of pregnancy, mifepristone, misoprostol, that we are going to give on day 1, day 3. That is different. That is maternal termination of pregnancy. Don't confuse with abortion and maternal termination of pregnancy. Maternal termination of pregnancy is different, right? Abortion is different. Abortion is totally different. Abortion is naturally occurring process. It is due to external thing. We cannot able to identify. But medical termination of pregnancy, it is related to this elective process. Maternal, that is MTP, is a elective process. Under the mother consent, under the woman consent, we are going to do the termination there. But in abortion, without cause, due to risk factors, the abortion is happening. So don't confuse with abortion and MTP. There is no drug of choice for abortion. Please keep in mind, we are going to manage the condition. The normally situated fetus is there. Somehow there is a problem in viability. It got aborted. What we are going to do? What we are going to manage? The situation happened, how we are going to do? But MTP, normally situated fetus, the viability is there, but we are going to abort. If there any chromosomal defect also, we are going to do MTP only under the criteria and guidelines. That is different. This is different. Okay. Yes. Abortion is different and MTP is different. Okay. Yes. Abortion we will discuss. Yes, we will discuss. Cervical insufficiency, incompetence, that is definition. What we are, that is painless due to cervical abnormality, due to the dilatation of the cervix in the trimester 2 or trimester 1, then we can say that is cervical insufficiency. Painless, spontaneous dilatation of the cervix, that is internal os is open, external os and internal os is there. Internal os is opened due to cervical shortening. Normally you can see this is the cervical pathway. Okay, this is the cervical pathway. This is the uterus. Consider this. If there is a shortening of the cervical due to internal os and external os between that, if there is a shortening there, then we can say the cervical incompetence is there, cervical insufficiency is there. So this leads to recurrent painless second trimester pregnancy abortion. Second trimester, if they ask second trimester abortion painless, if the word is there, then it is due to cervical insufficiency. Another one MCQ. Wherever I am telling the important MCQ, just make a note. Okay. If there is painless trimester 2 abortion is there, painless, if the word came painless recurrent second trimester abortion, then it is due to cervical insufficiency. Okay, it's due to cervical insufficiency. If they ask trimester 1 abortion uterine cause, that is septate uterus. That is different. This is different. Okay. Yes. Complete miscarriage is also dilatation and curettage only. We are going to do, the product is stuck inside. What we are going to do? We are going to expel it out. Okay. Yes. Today I am very happy. Lot of students are they are giving lot of inputs and everybody is quite interactive. Very happy, very happy. Greeny, Adira, Naresh Kumar, that is Stijita, Vlog, everyone, and Madhuri, everyone are very interactive to this session. Thank you all. Next, how we are going to diagnose. Till now we have discussed cervical incompetence, right? In cervical incompetence, how it is happening, I have discussed you the MCQ also. Now we are going to do diagnosis. Here comes the question also. History based. Okay. Mother comes. Okay. If it is more than 2 painless second trimester abortion, there is no other mode of diagnosis, no USD, nothing. What we are going to do, cervical insufficiency is confirmed, then cervical circlage we are going to do. Simple term, if there is 2 or more painless second trimester pregnancy loss, if the mother says, then we are going to do cervical circlage is confirmed, that is cervical insufficiency is confirmed, circlage we are going to do. Okay, circlage in the sense what? This is the cervical pathway, we are going to suture here. Suture we are going to do. Okay, yes. Coming on to the UST findings. Trimester 1, trimester 2 abortion is there. In trimester 2, single abortion if there is a chance. Then if there is 1 trimester abortion history, then we are going to do TVS. 2, no USD is needed. Cervical circlage is confirmed. Okay. Then cervical length, it should be less than 2.5 centimeter dilatation. If this is normal, 4 centimeter in pregnancy is quite normal. If it is less than 2.5 centimeter, cervical length is less than 2.5 centimeter, it is quite abnormal. What is a normal is 4 centimeter. Normally the cervical length is 4 centimeter. If the cervical length shorts 2.5 centimeter, there we can say that is cervical insufficiency is there. Okay, that is cervical insufficiency here. But what is the shape? There are several uterus shapes. The cervical component, there is lot of shapes. If U-shaped uterus is there, that is quite very difficult. It is funneling there. Okay, it is funneling there. What are the cervical shapes on transvaginal sonography progression? T is there, Y is there, V is there, and U is there. It progresses. T is more worse than Y is more worse than V is more worse than U is the most worst thing in cervical insufficiency. If there is a chance, okay, these are the types. Okay, this is T-shaped uterus. This is V-shaped. This is Y-shaped, and this is U-shaped. This is U-shaped uterus. These are the important points. Which is the very worst here? U-shaped, having more chances for abortion. More chances for abortion is more chances for abortion. Okay, yes. So MTP is quite different topic. Don't confuse with abortion. Okay, abortion is different. In medical condition, we can do medical termination of pregnancy till 20 weeks, but we can, it is approved till 24 weeks under the guidance of 2 regional medical practitioners, and the condition if the contraceptive is failure. Oral contraceptive they have started, right? In MTP we are having 2 criteria. Within 20 weeks we can terminate the pregnancy. If the termination of pregnancy is done by oral contraceptives, if the contraceptive fails, then we can go up to 24 weeks under 2 regional medical practitioners should be there. Under the 2 opinions only we are going to do MTP there. Okay, it is clear? Yes. Srijita, have you got? Yes. Second one is Y-shaped. Yes, this is Y-shaped. Sorry, this is Y-shaped. This is V-shaped. This is U-shaped. Okay, this is T. This is V. This is Y. This is yes. This is Y. This is V and U. I will write here. This is T-shaped. This is Y-shaped. This is V-shaped. This is U-shaped. Okay, T, Y, V, U. Okay, is it clear? T, Y, V, U. T, Y, V, U. Okay, is it clear for you all now? Is it clear? Yes. This is not I, don't confuse. This is T. Okay, yes. T, Y, V, U. Yes, correct. Srijita, you are correct. Is the doubt clear for you all? If without medical condition, any pregnant female can terminate her pregnancy up to 20 weeks, there is no possibility. Don't do that. Okay, don't do that. We are not encourageable towards that. There is medical conditions. We have to, MTP is done under the legal aspects. Under the consent of the woman, we are going to do. Under medical act, that is MTP Act 2022 is there. Only the consent of the woman is enough. Okay, yes, it's clear. This is T, this is Y, this is V, and this is U. Okay, which is the most worst thing? That is Y, that is U. Which is the MCQ point here? That is U. MCQ point is U here. Okay, yes. What is the management here? First line, for trimester 1 abortion we have done, right? Trimester 2 abortion, painless is different. Trimester 1 abortion with history of 1 abortion is there. Progesterone we are going to give with no history. If cervix length is less than 2.5 centimeter, no major history, then we are going to give only progesterone. For the endometrial thickness, you all know which hormone maintains pregnancy? That is progesterone only. Yes, U is the worst, correct. Which hormone maintains the pregnancy? That is progesterone. PP, you just remember. Circlage, it is indicated if 2 or more painless trimester 2 abortion is there, then we can do cervical circlage there. Okay, trimester 2 abortion or transvaginal ultrasound shows cervix less than 2.5 centimeter, then we can use this. If USG shows U-shaped uterus and cervical length is 2.5 centimeter, then we can give circulage. Okay, both, where we'll be giving both circulage plus progesterone. If circulage and progesterone is required, we can give, and we are going to discuss the types of circulage in next slide. If trimester 2 abortion plus transvaginal sonography shows this point, then we can give circulage and progesterone with history of 2 painless vaginal trimester 2 abortion. Okay, yes. And here comes the point. We are having 3, that is transvaginal, transabdominal and non-pregnant. In non-pregnant, we are using this last procedure. I will tell. First thing which is very important, that is McDonald's suture. Repeated MCQ. Okay, yes, McDonald suture, that is McDonald's circulage also we can say. What aspect they are using? This is the most common thing. Purse string suture we are using. Important. In McDonald's suture, what type of suture material we are using? That is non-absorbable, but method, that is purse string suture we are using, and it is done at transvaginally. Okay, it is done at transvaginally. You can see here. Okay, yes. Then Sirodhakar, this is the same principle, but buried suture we are going to do. Buried suture we are going to do. Okay, buried suture we are going to do. Okay, transvaginal only. Buried type suture material we are going to do. Here you can see the difference. Okay, yes. Coming on to this transabdominal, where Benson and Durfee, this is the technique we are going to do under laparoscopic. We are going to, what is the indication? Failed vaginal circulage, we are going to do transabdominal, and suture must be removed after family is complete. Another one thing I forgot to discuss, when it can be applied, that is 12 to 14 weeks. 12 to 14 weeks, this cervical circulage can be applied and removed less than 37 weeks. Okay, I will write here, it is applied on 12 to 14 weeks, mid of trimester 2, and it is removed less than 37 weeks. Okay, less than 37 weeks it has to be removed. Complete, the suture must be removed after the family is complete. Okay, if the family is complete, there is no possibility of pregnancy, right? If the couple decided not to get pregnant again, then we can remove the suture. Okay, yes. Last procedure, that is laparoscopic assisted supracervical hysterectomy. Without disturbing the cervix, we are going to remove the uterus. That is the procedure. That is for non-pregnant women, and it is rarely done due to complication. There is possibility of rupture also. Yes, wait for 3 months before conceiving. Okay, hysterotomy, not removing the uterus. Hysterotomy we are going to do. We are going to correct the cervical length here. Okay, that is the last procedure. That is for non-pregnant women we are going to do. Okay, it is rarely done due to complications. There are most probability for that uterine, we are going to disturb the uterine layers, right? There is chance of uterine rupture. Cervical lengthening is maybe got ruptured also, so that we are not going to do. But we can, if it is implemented, 3 months we have to wait for conceiving. After done the procedure, we have to wait. Okay, that is the important thing. Note, 12 to 14 weeks is ideal for applying cervical circulage. If it is diagnosed in trimester 2, mid of trimester 2, we are going to diagnose the trimester 2 abortion, is cervical insufficiency is there. Ideal time we can apply, that is 12 to 14 weeks. We have to remove before 37 weeks. Okay, yes. Yes, but as per book it is 14 to 12 to 14 weeks. Okay, yes. That is, here it is transabdominal circulage. This is transvaginal circulage. Yes, okay. Now it is 12 to 14 weeks. Okay, remove the stitch at 37 weeks. Okay, the mode of delivery: vaginal if transvaginal circlage, if transabdominal C-section is, because transabdominally the suture is applied, we cannot remove, so we have to do C-section. Okay, as per book it is 12 to 14 weeks. I will confirm and I will tell, but as of book that is 12 to 14 weeks it is given. Okay, 12 to 14 weeks it is applied. Okay, within 37 weeks we have to remove. Okay, yes. Coming on to this contraindication, womb and all we are not going to do. Ruptured membranes, chorioamnitis is detected, no circlage. Active bleeding, no. Uterine contractions are high, we are not going to do. Okay, fetal demens or major anomalies detected, no circlage. Cervical dilatation more than 3 centimeter, less than 2.5 centimeter only we are going to do. Normally in pregnant 4 centimeter dilatation is good. That is dilatation in the sense cervical length. Okay, if cervical dilatation is more than 3 centimeter we are not going to give. Okay, active pelvic infection, no. What is the relative contraindication is placenta previa. This is the important MCQ point you should note. Okay, yes. Lash is laparoscopic assisted supracervical hysterotomy. Okay, hysterotomy. Without disturbing the cervix, we are going to length the cervical thing. Okay, yes, you are going to approach the thing. Till now it is clear for you all, children. Shall we practice the MCQs? Before that, give me 2 minutes. Yes. Yes, sorry for the interruption. The class is good, don't be confused. Okay, as of book only I have told everything. U is the most, yes, everything is correct. Now we are going to practice the MCQs, right? First question, have you got the answer? A 26-year-old woman presents with painless vaginal bleeding at 18 weeks. Painless vaginal bleeding at 18 weeks. TVS shows cervical length, transvaginal sonography shows 2.2 centimeter with U-shaped funneling. What is the next best step? Bed rest only, cervical circlage plus progesterone, MTP, immediate delivery. Yes, come on, tell. Yes. Adrita, you are correct. That is cervical circlage plus progesterone. Cervical circlage plus progesterone. First, identify the keyword here. Painless vaginal bleeding is there, 18 weeks. So, cervical length is 2.2 centimeter. 2.2 centimeter, less than 2.5 centimeter, right? Then, what is the next step they are asking? Cervical circlage plus progesterone. Okay, yes. Next question. Is correct. A 30-year-old woman has 3 consecutive painless second trimester abortion. What is the best management? We are going to do progesterone 1 and TVS to confirm the cervical length, immediate circlage without USD, circlage at 28 weeks. Come on, tell me. Anyone? A 30-year-old woman has 3 consecutive painless second trimester abortion. Yes. See, trans-abdominal in the sense, we are only correcting the cervical length there. We are not disturbing the normal menstruation. Cervical length is reduced na, so there is a problem in pregnancy only, not problem with the bleeding, not problem with the normal physiology. We are not going to disturb there. Okay. Yes. Yes. Don't think too what to say advancedly. Think in a basic level so that you can get the answer clearly. Okay. Yes. Yes, that is immediate cervical circlage without USD. So with, if there is one history of trimester to abortion, then we can give only progesterone. Okay. Yes. Next comes a woman with threatened abortion. They have given presence with mild pervaginal bleeding, cervix is closed, management they are asking, suction evacuation, emergency DNC, expected rest, serial USG, circulage immediately. Come on, tell. Yes, expectant. In threatened abortion, whether the fetus will be viable or not, whether the fetal heartbeat will be there or not. Anyone? Come on. Yes, fetus will be viable. In threatened abortion, it will be viable. Okay? Yes. Coming on to the next question. A patient at 10 weeks with USD shows crown rump length of 8 mm with no cardiac activity. What is the diagnosis? At 10 weeks with USD shows crown rump length of 8 mm with no cardiac activity, what is the diagnosis? Viable and threatened. May or may not, will not be there. In inevitable only will be there. Okay? Yes. Next question. Come on, you are going to answer. Okay? In threatened, fetus is viable. Right, right. Everyone is correct. Why incomplete? Why incomplete you are telling, Priyanka? Already I have told several times, crown rump, why missed abortion I specifically told, they may give you the question, okay? They may give you the question, there is no, you can see the question, there is no clue for abortion. They have not mentioned anything. Only they have mentioned the crown rump length with the no cardiac activity they have mentioned. Then how you can say that is incomplete abortion? In incomplete abortion, what is exactly happening? The cervical os will be opened and the fetal parts are coming out. The product of conception are completely out. That is in incomplete abortion. Okay. Yes. Next question. Yes. Missed abortion. We are having the fetus will not be viable. Crown rump length and mean sac diameter, it will be greater than 25 mm, and what will be no fetal, no sac and no fetal pole will be present. Okay. Yes. Next question. A woman at 14 weeks has pervaginal bleeding. Okay. Cervical os open. Okay. Cervical os is open. No product of conception expelled. Best diagnosis. No product of conceptions are expelled. It will be threatened abortion, incomplete abortion, complete abortion, missed abortion. It is easy to answer now. If threatened abortion, the cervical os will be closed. Incomplete abortion, it will be closed. In missed abortion also it will be closed. Only in incomplete and inevitable the os will be opened. Is that correct? Yes. Is it fine, children? So, inevitable abortion, no product of conception will be expelled, but in incomplete it is expelled. Some parts will be expelled, but in complete all the product of conception will be expelled. Okay, all will be expelled completely. Products of conception will be expelled. Okay, yes. Is it correct? Now, patient with pervaginal bleeding and partial expulsion of products, cervix open, bleeding persist. Next step. So come on, what is the diagnosis here? Partial expulsion. Come on, don't answer this. Give me the diagnosis. Which type of abortion is this? Okay, some partial expulsion of products, cervical os open. First tell which abortion is this, then you can go for the action. Okay, yes. Come on. Okay, you are correct. Emergency suction evacuation, it is correct. Now tell me which abortion is this? What is the abortion? What abortion is this? Yes, correct. Incomplete abortion. Incomplete abortion. Is it correct? Yes. Wait for spontaneous completion. Why? Because in incomplete, okay, in incomplete there is chance of heavy bleeding. Okay, in incomplete there is chance of heavy bleeding. Pain will be there. The product of the conception products are coming out, expelled out, partially it is coming out. Then why we are going to delay? We are going to emergency, we are going to suction evacuation. What happens if we leave? What happens with bleeding? The mother may go for hemorrhagic shock. Hemorrhagic shock, and it is the life-threatening situation. What will be the management there if we left? After suction and evacuation, we have to monitor vitals, then fluids, NS we are going to give, and assess for bleeding. Okay, and blood transfusion. Okay, yes, hemorrhagic or hypovolemic shock. What may be the symptoms? It may be tachycardiac and hypotension. There will be chance of hypoventilation. If hypoventilation is there for this shock, then the mother will be going for what? Respiratory acidosis. Respiratory acidosis. This is the mechanism what going to happen if this abortion is untreated. Okay, yes. Is it clear now? Yes. Coming on to the next question. A 14-week pregnant woman presents with heavy bleeding, passage of some products of conception. Okay, on examination the cervix is open. Ultrasound shows retained products of conception in the uterus. What is the likely diagnosis? Yes, correct. Everyone is correct. Adrita, Srijita, Greeny, everyone correct? Yes. Yes. Cervix is open. Ultrasound shows retained product of conception in the uterus. What is the most likely diagnosis? How? See, you are telling. In incomplete, already we have discussed, right, in the previous slide. This is incomplete abortion. Here, partial expulsion of products are there. In incomplete, I have told partial expulsion of products will be there in incomplete abortion. Here, what is the question? The scenario is same. Cervix is open. Ultrasound shows retained product of conception. Then how it will be incomplete? Retained product of conception in the uterus, then how it will be incomplete? Don't confuse here. So that I am repeating 2 or 3 times. Okay, so that only I am repeating. Partial expulsion, then it is incomplete, but products are remained. In the first slide, what I told, you can see the first slide. I will be going for the first slide. Don't worry. In incomplete, you can see partially expelled, some products remain inside. Some products only remaining inside, but in inevitable, no products will be coming out. No products will be coming out. That what I am keep on stressing you people. Okay, I am keep on stressing you people. Okay, here, yes. Now you can tell the answer. The retained products of conception is there. Okay, you can read the question twice, so that a 14-week pregnant woman, they have told heavy bleeding is there. Heavy bleeding, passage of some products, but in inevitable mild pain will be there. Okay, but sometimes heavy bleeding they may give. There is no point of pain they have mentioned, right? There is no point of pain they have mentioned. No pain they have given. If pain is given, then you can go, then you can think about incomplete abortion. They are not given about the pain. They have given heavy bleeding and passage of some products of conception. Some they have given on examination. Here they made some confusion here. Okay, cervix is open. Ultrasound shows retained products of conception in the uterus. Here they confused you. Here you can see here. Okay, where I will make the highlighter. Okay, here passage of some products conception they have given. This is one keyword, but on ultrasound what they have confirmed, always gold standard is with ultrasound. Okay, always gold standard is with ultrasound. Ultrasound shows retained products of conception in the uterus. Retained products in the uterus, but this is not your keyword. This is to confuse you. But ultrasound shows the retained products of conception in the uterus. So now you may go answer C, but the exact answer is inevitable abortion. Okay, because always gold standard is what? Always gold standard is ultrasound. Now you got the point? Here on examination, this is the keyword you should note. The cervix is open, so it may be incomplete or inevitable. 2 points. No other options will be there. So I am going to neglect this. I am going to neglect this. So either this or this. This may be the answer. Now, what is the another keyword? Ultrasound shows retained products of conception in the uterus. So products are retained. Only one condition will be having retained components, products of conception. Here they may giving, okay, if pain is given, then you can go for incomplete abortion. There is no history of pain, then you should think only inevitable abortion. Okay? Yes. Coming on to the next. A woman with history of second trimester abortion. On transvaginal sonography, the cervix is 3 centimeter long. What is the next step? Second trimester abortion. Okay, history of 1 second trimester abortion only. On TVS, cervix length is 3 centimeter. What is the next step? Only 1 second trimester history of abortion. What is the condition here? It is, what is the condition here? Retained means some part remains or complete part inside the uterus. The products of conception is placenta, fetus, everything. That is the products of conception which is retained in the uterus. It has to grow, right? If it is coming out, that is abortion, abnormal thing happening. In inevitable, the products will be inside. It will not come. In incomplete, partially it is coming out. But in complete, everything is coming out. But the cervical os remaining closed. But in inevitable and incomplete, the cervical os remains open, so that there is a bleeding. In compared with inevitable and incomplete, incomplete has heavy bleeding with pain. Moderate, severe pain will be there. But in inevitable, mild pain with mild bleeding. Sometimes it may be heavy bleeding will be there. Okay, this is the core concept you should understand. In inevitable, the product of conception will be retained inside the uterus. In incomplete, the partially somehow there is a product of conception will be coming out. So that is the key point you should differentiate. Okay? Yes. Now I hope you got the concept clearly, right? So come on, answer this question. Yes. History of second trimester abortion. Okay? Is it correct? Am I got? You got the answer? Yes, only progesterone. If it is 2 second trimester abortion, if it is 2 second trimester abortion, then we can go this answer. There is 1 second trimester abortion. Okay, this is very easy question. They may not give you the easy question. They may give like this question to confuse you. Okay, for that only I get this question for you all. Okay, yes. Yes, only progesterone. History of 1 trimester 2, the cervical length is 2.5 centimeter, only progesterone, no circulation. Okay, yes. Next question, shall we go to the next question? A woman with history of 2 painless second trimester abortion now presents with pregnancy. What is the McDonald's circlage ideally do? So they have given trimester 2 abortion, cervical insufficiency, indirectly the condition is revealed. Now what is McDonald's suture ideally done? McDonald's suture ideally done at 8 weeks, 12 to 14 weeks, at 28 weeks, after 37 weeks. Okay. See, maximum we can do up to 18 weeks, but ideally, ideal is the sense that is 12 to 14 weeks only. Okay. Yes, ideal. Yes, again you are having confusion na. I am telling na. It is to confuse you people. They have given you. Once again, I will erase everything and I will tell. Okay. Don't confuse your children. Okay. They have given, this is the history. This is the history they have given. Okay. This is the history they have given. Okay. Bleeding and passage of some products of conception. Some they have given. They have not mentioned partial. They are not given full. But on examination, it is not confirmed. But on examination, the cervical is open. Then ultrasound shows retained products of conception. It may be some other thing also, but ultrasound is the gold standard thing. Like transvaginal sonography and ultrasound is the ideal gold standard diagnosis. In that there is products of conception are retained inside. Then why you are going to click incomplete? In incomplete, partially the products of conception will be coming out. In ultrasound also is going to tell the same only. Why we are going to give incomplete? So it is inevitable. Okay, it is inevitable. If USD there is partial products are coming out, then you can click incomplete. But in incomplete there will be pain present. Pain will be present na, so there is no pain. Yes, heavy bleeding sometimes present in inevitable also. So sometimes there will be pain in inevitable also. Okay, yes. Next question, is it clear for you all? Cervical McDonald's circlage ideally done at 12 to 14 weeks. Yes, clear. Next, a woman with recurrent first trimester loss is found to have APLA syndrome. What is true? It is the most common cause of recurrent pregnancy loss. It causes cervical incompetence. Subtate uterus is more common. No treatment available. APLA syndrome. Yes. On that question, yes, Greeny, you are correct. You can take a point on USD because that is the gold standard. Yes. Come on, answer this question. Recurrent first trimester losses is found to have APLA syndrome. What is true about it? It is the most common cause of RPL, recurrent pregnancy loss. That is recurrent pregnancy loss. Septate uterus. If you think about septate uterus, it is the most common uterine cause. It is most common uterine cause. But when you think about first trimester APLA syndrome, then it is the most common cause. Okay, most common cause. If it goes to second trimester, what is the most common cause? Yes, 16%, correct. Then if it is goes to second trimester, they have not given any condition, what is the cause? Come on, tell me. Anyone? Yes, you can tell. Anyone can tell? What is the cause if trimester 2 abortion is there? Trimester 2 abortion is there. Come on. Yes, cervical incompetence. Uterine abnormality always will detect on first trimester. Chromosome also first trimester abortion. Okay? Yes. Next question. According to WHO, abortion is defined as pregnancy loss before. This is easy question. You are going to answer. I am going to read the options. At 24 weeks or less than 500 grams. At 28 weeks or less than 1000 grams. At 20 weeks 500 grams less than. At 22 weeks less than 350 grams. Come on, tell. Yes, correct. Everyone is correct. I hope you got the definition right. Abortion is defined as loss of pregnancy before 20 weeks under or the fetus weight less than 500 grams. At 20 weeks, the fetus weight will be 330 grams. Okay, at 22 to 24 weeks, it will be 500 grams. Okay, is it clear? Yes. Coming on to the next. Most common chromosomal cause of first trimester spontaneous abortion. Here, triploidy, trisomy 16, monosomy X, balanced translocation. Here comes the confusion question. I hope it is confused. If I am the student, come on, anyone can answer, right? Yes, this question. Not more than 500 gram, it should be less than 500 gram. Less than 500 grams. 20 weeks, less than 500 grams, that is called abortion. Let you people can answer. Yes, you can answer. Triploidy, trisomy 16, monosomy X. Yes, if it is comes, first option you should give for aneuploidy. Aneuploidy, you can give the first preference. If it is not there, then you can go for what? If it is not there, so I will take you to the first slide now. I will take you to the first slide. You are going to answer. Here, spontaneous abortion. First is aneuploidy. Second is trisomy. Next, monosomy X. Then trisomy 16. Okay, trisomy they have given. Okay, trisomy 16 they have given. First, second priority. In that question, what is the answer? Yes. What they have given? Triploidy they have given. It is not triploidy. First preference we have to give for trisomy. So what will be the answer here? It is trisomy 16. Trisomy is the first option. Then only we can go for monosomy X. First is always aneuploidy. You may have the question aneuploidy. Okay, aneuploidy is the first thing. Trisomy 16 is the answer. Okay, yes, this is the answer. Next question. Most common uterine cause of second trimester abortion. Most common uterine cause of second trimester abortion. Septate uterus, biconjugate uterus, cervical incompetence, fibroid uterus. Now you can tell. Most common uterine cause of second trimester abortion. Yes, it is cervical incompetence. In second trimester abortion, you can say this. First trimester, that is septate uterus. That is in first trimester. Okay, that is in first trimester. Okay, yes. Next question. A patient with threatened abortion has cervical finding. Cervical os is open, cervical os is closed, cervical canal dilated, internal os is incompetent. In threatened abortion, what is going to happen? Okay, fetus life. Fetus is alive or death. Cervical os is opened or closed? Yes, it is closed. In incomplete and inevitable, it is open. Okay, then in missed abortion, crown rump length, if it is greater than 8 and fetal cardiac activity will not be present under USG, then it is missed abortion. Okay, don't confuse, don't confuse. In missed abortion, which of the USD finding is diagnostic? Okay, I reveal the answer, but anyhow you should answer. Main sac diameter is greater than 20 mm with no yolk sac. Crown rump length greater than 7 mm with cardiac activity. If crown rump length is greater than 7 mm with no cardiac activity, MSD greater than 10 with cardiac activity. Yes, fetus is alive. You are correct. Yes, correct in threatened abortion. Yes. I think I revealed the answer so that you guys answered correctly. Yes, you guys answered correctly. Thank you, children, for understanding. Yes. Why A? Mean sac diameter should be greater than 25 mm. Already I have told. So you are having confusion. Use the neglect, that is elimination criteria. I am going to apply. I am going to apply elimination criteria here. Okay. Missed abortion, I know, mean sac diameter and crown rump length. I am having confusion whether it is 20 or 25. So let us correlate. Crown rump length is 7 mm with cardiac activity, no. So it is having confusion, so I am keeping it. Okay, crown rump length mm is correct with no cardiac activity. Yes, I can keep this option. MSD will not be 10, right? So I am neglecting. Either I am having confusion with this or that. Okay, but which correlates the most? This one will correlate most. Okay, crown rump length is 7 mm with no cardiac activity. This is gives the confirmation. Okay, this gives the confirmation. So I am going for the option C. Okay, don't confuse between this. Use elimination criteria, then answer. Then you will be getting the answer. Correct? Yes. Shall we go for the next question? Yes. A woman with missed abortion diagnosed by crown rump length of 9 mm without cardiac activity. What surgical management, what procedure will you advise? Expected management, mifepristol induction, suction and evacuation, emergency laparotomy. Missed abortion is there. Okay. Come on, tell me the answer. Yes, it is suction and evacuation. Okay. Yes. Expected management will be doing for what condition? Expected management will be doing for threatened abortion. Mifepristol induction, that is MTP, that is totally different. And emergency laparotomy we are not going to implement here. Okay. Yes. But they have given abortion. Okay. To control bleeding we can give. Okay. For missed abortion, okay, missed abortion, what point in giving mifepristol here? Already the fetus is dead. Then what point we are going to give there? We have to do suction and evacuation there. Okay. Yes. If there is bleeding we can give. Okay. Then next question. A 26-year-old woman presents with vaginal bleeding and mild lower abdomen pain at 10 weeks of gestation. Ultrasound reveals a viable intrauterine fetus. Okay, with cardiac activity, the internal os is closed. What then? No products of conception are expelled. What is the appropriate management? Now you are going to answer. Vaginal bleeding is there, mild lower abdomen pain is there. Where is the cervical os here? Cervical os is closed. And what may be the management? Immediate suction and evacuation, expected management with serial ultrasound, misoprostol administration, emergency circulage placement. at 10 weeks we are not going to do this. Okay, expected management. Okay, ultra vaginal bleeding is there, mild lower abdomen pain is there. What is the abortion? Now tell me, what is the abortion? Cardiac activity is there, intrauterine cardiac activity is there. So what is the abortion here? And internal os is also closed, and no conception, that is products of conception are not expelled out. So what is the condition, and tell me the management. It is very easy only. We are going and repeatedly seeing the same questions. Why I am repeatedly telling now, then you will be having a clarity towards that question. Okay, yes, it is threatened abortion. We are going to manage with serial ultrasound. Okay, yes. Next question. A 29-year-old woman with history of 2 painless second trimester pregnancy loss is currently 13 weeks pregnant. Okay, 2 painless second trimester pregnancy loss is there, and 13 weeks are pregnant. Currently she is pregnant. Transvaginal sonography shows a cervical length of 2.3 and U-shaped funneling is there. So what is the next management? Next management is immediate delivery. Okay, start progesterone only, place McDonald circulate, observation only. Come on, tell me. Yes, we are going to place McDonald circulate because it is 13 weeks. Okay, because it is 13 weeks. Okay, yes, you are correct. Now you got the point. Now you are on the track, right? A 32-year-old woman presents at 18 weeks of gestation with painless expulsion of products. Painless expulsion of the products of conception. On examination, the cervical os is open and continued bleeding. What is likely diagnosis? Now you tell. Having with painless expulsion of parts of products. Painless expulsion. On examination, the cervical os is open. Cervical os is open in incomplete and inevitable. What is the most likely diagnosis? Now you are going to answer. Okay, products of conception, some parts are coming out. Expulsion of the products of conception with painless expulsion part of the products. Cervical os is open, continued bleeding is there. Okay. Yes, it is incomplete. Now you got the point. Yes. Now you got out of the confusion. Yes. Next question. A pregnant woman at 32 weeks of gestation has a cervical length of 2.4 centimeter, V-shaped funneling on transvaginal zone. She has no history of pregnancy loss. What is the recommended management? Start progesterone and monitor. Circulate immediately. Emergency C-section, tocolytics and observation. V-shaped funneling has cervical length of 2.4 centimeter. This point you should note. And she has no history of pregnancy loss. This also you should note. Yes. See, in incomplete there may be pain. There will be pain. Sometimes there won't be pain, but bleeding will be there. Persistent bleeding will be there. But in inevitable, there will be mild pain. Okay, in incomplete there will be heavy bleeding. Heavy bleeding will be there. Bleeding will be persist. If there is a term, pain may be present or not, that is different. But bleeding will be heavy, persistent bleeding will be there in incomplete. Inevitable mild pain. Mild pain, but in incomplete there may be heavy or painless. But bleeding will be constant. So that you should remember that. Okay, yes. So here there is no history of what? There is no history of pregnancy loss. There is no history of pregnancy loss. There is no history of pregnancy loss. Yes, now you are going to tell. ABD tocolytics observation. Why this much? There is no history of pregnancy loss. Then why we are going to do circlage immediately? She is 22 weeks already. She has crossed the time, and emergency C-section not possible, not possible, not possible. And tocolytics and observation. Why? What the point in giving tocolytics here? Okay, cervical length is shortening. V-shaped funneling is there. U is most. Then there is no history of pregnancy loss. Then we have to start progesterone and we are going to monitor because she have crossed the ideal time. Okay, yes. Here comes the question. Our own reasoning and assertion. We are going to fight here. Okay, cervical insufficiency typically causes painless second trimester abortion. And in cervical insufficiency, the cervix dilates prematurely without uterine contractions. In cervical insufficiency, the cervix dilates prematurely without uterine contraction. Cervical insufficiency typically causes painless second trimester abortions. Yes, it is correct, right? Yes. What is the answer? You are going to answer the question. Yes? Yes? Tell me, what is the answer? Yes. Both A and R are true, explanation of A, or both A and R are true, but R is not correct explanation of A. A is true, R is false. A is false, R is true. Here, cervical insufficiency will cause trimester to abortion painless. Reason, cervical insufficiency will dilate without uterine contraction. That is the correct answer. A will be the correct answer here. Okay? Yes. So, if reasoning and assertion question comes, don't attempt immediately. Take time, read the question and answer. Okay? Yes. Though it is easy, it is tricky. Progesterone supplementation is used in women with short cervical length. Progesterone supplementation is used women with short cervical length. Okay. Progesterone promotes cervical ripening and uterine contraction. Progesterone promotes uterine contractions. Now you tell. Yes, come on. Progesterone promotes uterine contraction. This is true, and progesterone supplementation is used in women with short cervical length. Come on, anyone? Let me see the answer. A is true or is false. Why? Progesterone will not promote, will reduce the cervical ripening and uterine contraction. So, A is true or is false. Okay. So that this is very simple concept, right? With progesterone they have made this question. So to make you confusion, they have given this type of question. Okay. Yes. Next question. Missed abortion requires surgical or medical evacuation. Yes. In missed abortion, the fetus is not viable but retained within the uterus. Is it correct? Is it correct? Yes. Progesterone will prevent cervical ripening. It reduces the cervical ripening and uterine contractions also. Okay. Coming on to the normal physiology in labor, functional withdrawal of progesterone will be there. So if progesterone withdrawal only, there may be increased estrogen, increased oxytocin, and increased gap junctions so that uterine contractions are happening. Okay, if it is not there, if no progesterone, it happens. If progesterone is increased, there is no possibility there. Okay, yes, yes, both are right. Both A and R are true. R is the correct explanation of A. Okay, yes. Next question. McDonald's circlage is preferred over Shidoka circlage in routine cases. Yes. McDonald's circlage uses simple bursting suture technique. Yes, it is correct or not? Come on, you are going to answer. Come on, children. Yes. Why you are giving C? McDonald's circlage is preferred over Pseudocurt circlage in routine cases. Which is the most common suture we are using? That is always this McDonald's circlage, right? Then McDonald's circlage uses a simple bursting suture technique. Okay, let me check the answer. Yes, this is the answer. Both A and R are true. R is the correct explanation of A. Okay, yeah. Why you are giving C? C is not true. McDonald's suture is the most common suture, right? Is the most commonly used suture, and McDonald's circlage has a mechanism, that is bursting suture technique. Yes, it is trans-abdominal or trans-vaginal. You are going to answer. It is trans-abdominal or trans-vaginal. McDonald's circlage is trans-abdominal or trans-vaginal. Simple bursting, it is a non-absorbable suture, right? Non-absorbable suture we are going to do, and it is applied transvaginally. Whichever time persists we can give, but Pseudocurt technique is using the same principle, but we are using it a buried form. Buried form we are using. I will explain with this picture. Okay, yes, here comes. This is Pseudocurt technique. Okay, it is used in the buried form. It is used in the buried form. It is also non-absorbable only, but you can use this McDonald's, it is most common. Okay, yes. Till now we have discussed about all the MCQs and what are the expected questions we have discussed. Okay, we have came to the end of the session. If there any doubt regarding that, you can ask me the question, so that this is my Instagram page officially. You can ask your queries and doubts. Okay, students, is there any doubt? You can ask me. Okay, yes, it is applied 12 to 14 weeks, removed before 37 weeks. That is the important point you should take home. Okay, yes, whatever topics, whatever important things I have told you to write, which is the MCQ point, you can make a note which will be reflecting in your exam, damn sure. If abortion, if the question comes from this only, damn sure the questions will be. Okay, today we have done with 2 MCQs. If they asked in prelims, 1 MCQ, in 1 MCQ can be asked from mains also. Okay, yes, either in prelims or in mains, 2 questions is damn sure from this session. Okay, yes. My name is Muthukumaran. Okay, Muthukumaran from NNL Academy. I am the faculty here. You can, if you are preparing for your NORCET 9.0 and 10.0, we are having a plan, that is Plan C English Platinum Edition. You can explore the app NL1. You can go in the Play Store. Android version is there. You can explore the app NL1 app, so that you can have different types of plans regarding NORCET 9 preparation. We are having lot of plans you can explore, and you can approach us our RMs will connect with you, our counselors will connect with you. Okay, yes. Is there any doubt, children? Yes. Is there any doubt, so that we can wind up? Yes, strike batch, strike test is one of the beautiful tests which is prepared. Our masterminds have done this so that you can have much questions. Practice sessions will be there, practice MCQs more and more, so that you can crack the NORCET as much as possible. Okay, practice as much as MCQs daily. Okay, like this, what I have thought, like that only you have to practice the MCQs. First read the question, analyze the keyword, then go for the option. If the options are confusing, use elimination criteria, then answer the question. Or that, don't touch the question. Okay, yes. First identify the keyword, then answer the MCQs. Okay, yes. Yes, next session will be on Wednesday, and hopefully we will meet next week with the beautiful topic. Okay, yes. Thank you all. Thank you. Have a great day. All the best for your exams. Okay, yes.